First of all, I thank you all for joining us. And today's topic, still using multi-dose vials, and also we are going to cover advantages of articaine over lidocaine. And our guest speaker is none other than Professor Malamed. In fact, our today's guest needs no introduction at all. The reason for that, why I say, is that somewhere during your college days, you would have already gone through and read about Professor Malamed in his textbooks during your college days. Though Professor Malamed is going to introduce himself in the webinar, still let me just put in one line that Professor Malamed has authored more than 140 scientific papers and 17 chapters in various medical and dental journals and also in textbooks. This is a recorded lecture specially for Indian dentists. You can type all your queries in the chat section, which is on the right side of your screen. Professor Malamed will address all your queries when he'll come live by the end of this recorded version.
Good day. I'm Professor Stanley Malamed. I am a dentist anesthesiologist here in Los Angeles, California, where I taught at the University of Southern California School of Dentistry from 1973 until 2013. As a disclosure, I am a consultant for Septodont. Septodont is the world's leading manufacturer of local anesthetics, and our program today is all about local anesthesia. So I am the author of 3 textbooks. On the left, my book on sedation. On the right, my book on medical emergencies. And in the middle, my book on local anesthesia. Now, I know that my books are used in India. And in fact, on the left-hand side of the screen is the South Asian edition, most recent edition of my book on local anesthesia. I have been privileged, delighted to have been in India, well, live twice. Back in 2014, I was at the Federation Dentaire International meeting in Noida, and then in October of 2016 at the World Dental Conference in Mumbai. I would have had 2 more visits, but the pandemic got in the way. So the last one would have been at the World Endodontic Conference, which is going to be held in Chennai, which was done, both of these were done virtually. My email address, following the program, if anybody would like to contact me, asking, and I'll offer you to send you some information if you want on some of the subjects we're discussing here today. My email address is my last name, Malamed, usc.edu. So let's get going here. Pain. The #1 fear that dental patients have is fear of pain. People don't like being hurt. Well, we are very, very fortunate in our profession that we are using a great class of drugs. Local anesthetics are the major drug class that actually prevent pain from occurring. So in this animation, we have an infected maxillary right premolar, and every time that nerve impulse reaches that patient's brain, they're feeling a sharp stabbing, dull, aching, throbbing, whatever, you know, how they describe it. So now on the bottom right, we're putting a local anesthetic in. You can see the syringe coming in. We're depositing local anesthetic at or above the apex of the tooth. And as that drug diffuses into the nerve, the impulses going to the brain get weaker and weaker and weaker until finally the nerve is thoroughly saturated, as you can see right now. So the nerve is thoroughly saturated, and even though that tooth is still firing off, the nerve impulses are not reaching the patient's brain. So, I mean, simply put, if we deposit a local anesthetic close to a nerve, it will, in almost all situations, produce pain control. So what I would like to do in the next 40 minutes or so is talk about briefly the drugs and a lot about the local anesthetic armamentarium and one specific local anesthetic, and that is articaine. So let's start out with a quick discussion of the drugs. And Worldwide in the dental profession, these are the 5 local anesthetics that are available. So alphabetically, we go with articaine, bupivacaine, lidocaine, mepivacaine, and prilocaine. Now, in India, the availability is somewhat limited. You do have articaine available, we do have lidocaine available, and we do have bupivacaine available. So what I'd like to do then is let's take a quick look at the local anesthetics that are available in India and look at what we expect. What is the expected duration of pulpal anesthesia produced by these local anesthetics? So 3 categories. We have on the left, short-acting local anesthetics, providing pulpal anesthesia for half an hour or less. On the right, we have a drug that produces local anesthesia pain control for minimally 90 minutes. And in the middle, we have the intermediate acting drugs providing pain control, pulpal anesthesia for approximately 1 hour. And there are two available in India. We call these the intermediate acting drugs. Again, pulpal anesthesia, assuming, if you look at the bell-shaped curve on the right-hand side of the screen, assuming your patient responds appropriately to the medication, you should have about an hour of working time. And the 2 drugs we have are lidocaine with epinephrine and articaine with epinephrine. You are fortunate to have one long-acting local anesthetic, and this drug is bupivacaine. It goes by many brand names worldwide. The brand name I see here is Anowin. In cartridge form outside of India, we have what is called Marcaine. And this is an excellent drug, primarily used for post-surgical pain control. Now, at the end of a surgical procedure, and in most cases, you're going to use lidocaine or articaine for the anesthesia for the surgery. At the very end of the surgery, before you dismiss your patient, you then administer a nerve block with this drug. And given by nerve block, bupivacaine can provide up to 12 hours of pain-free time. Now, when this is done in combination with a non-steroidal anti-inflammatory drug, such as ibuprofen, virtually all patients following surgery, whether it's extractions, periodontal surgery, endodontic surgery, implant procedures, will be comfortable. In the dental profession worldwide, about 90% of local anesthetics that are used belong to this intermediate category. And the reason is, in most places worldwide, the average patient is scheduled for about a 1-hour appointment, and they're actually in the dental chair for, this is the United States, for about 40-45 minutes. And these drugs, all containing a vasoconstrictor, usually epinephrine, will provide these patients with a pain-free dental experience. So that's our brief, really, introduction to the drugs. What I want to talk a lot about, however, is the local anesthetic delivery system. And there are 3 major components to this, and that is the syringe, the needle, and the anesthetic drug. This is an email, just coincidentally, that I got on the 22nd of May. And it was from a dentist who recently came to the United States from India. So let me read some of this to you. This is from her email. And what she said is, I was practicing until last year. So this is 2021. I was practicing until in 2021 in India. I have only worked with plastic syringes and multi-dose local anesthetic vials. I would say that more than 80% of practicing dentists, if not more, use the same equipment. And I have to tell you that I was really surprised. I mean, I said I'd been to India twice in person, and I was unaware of this. The assumption, of course, is that everybody is using the same armamentarium for local anesthetics. Well, I did a little research here, and it turns out that in 2021, there were 197,000 dentists in India, where there are 331 dental schools, graduating 27,000 new dentists per year. And again, to me, surprisingly, 6%, only 6% of dental local anesthetics are used in cartridge form, where 94% of dental local anesthetics are used from multi-dose vials. And this really, I think this is the system that you're used to using. We have on the upper left, we have a multi-dose vial of lidocaine. On the right, we have a multi-dose vial of bupivacaine. And on the bottom, we have the Lurlock syringe, the plastic disposable syringe. Again, the plastic disposable syringe, and on bottom, we see the more traditional metal reusable, sterilizable dental syringe. Needles, on the left, using your Lurlock, your Lurlock system, there are a variety of needles that are available. And on the right-hand side, with the metal reusable, sterilizable syringe, there is also a variety of different needle gauges and needle lengths. So the multi-dose local anesthetic vial. In India, the two available local anesthetics are, and lidocaine on the left-hand side, 2% with epinephrine in a 1 in 80,000 concentration. And on the right, your bupivacaine for post-surgical pain control. It's a 0.5%, 0.5% with epinephrine. Two very nice drugs. Now let's take a look at the anesthetic cartridge for a moment, for a lot actually. And let's talk about this cartridge. Dentistry, local anesthesia actually began in 1906. The first local anesthetic injection was given in 1884, and it was cocaine with epinephrine. But dentistry changed. In fact, surgery worldwide changed with the introduction in 1906 of probably still the name, at least, the world's most famous local anesthetic. Now, Procaine is the generic name of the drug. The brand name of the drug is Novocaine. And back at that time, if you look at the picture, the dentist would come into the surgery in the morning, have a bottle of Novocaine tablets, and have to prepare his own local anesthetics. Well, World War I was fought from 1914 to 1918, and Harvey Cook was an army surgeon, army surgeon during World War I. And he didn't want to prepare his local anesthetics the way I just showed you. So what he did, he took used bullet cartridges, if you want to use that. He fabricated a brass syringe. He took cut glass tubes, and for the stopper, he used a pencil eraser. In other words, Harvey Cook designed the first local anesthetic cartridge. This is what they look like today. They come in a variety of sizes. We have the 2.2 mil, and we have the more commonly used 1.7 milliliter local anesthetic. Cartridges today come in what is called a blister pack, and we'll talk more about this in just a moment. They come in a blister pack. So here you see 8 cartridges unopened. They are aseptic, they are clean. No human being has yet touched them with their fingers. And they are packaged 50 cartridges in a box. Interesting, the number of dental cartridges that are used annually in our dental profession, just about 2 billion cartridges. The number one used local anesthetic worldwide in dentistry is lidocaine, where 1 billion cartridges are used annually, and number 2 is articaine with 600 million. So this is, again, back to that email from the doctor from May 22nd. After having worked with aspirating syringes here in the United States, I was hoping there was a way to bring that system to India. So what I want to do, I'm going to go through a comparison of the multi-dose anesthetic vial versus the cartridge. And again, you'll see this slide a little bit later again. And in green would be the advantage of either one of the two. And we start out with really the only advantage of the multi-dose vial versus the single-use cartridge, and that is the fact that a multi-dose vial over time is less expensive. But if you factor in the syringe, the Lurlock syringe that you are buying and using and then discarding, well, on the right-hand side of the slide, we have that metal syringe, which initially is more expensive, but it is reusable, it is sterilizable, and in all honesty, most dentists are using that syringe for years. So let's then talk about the aspirating syringe. It is designed for dentistry. It is our syringe. And you know that one of the most important things that we do before we deposit the local anesthetic is we aspirate, because we don't want to put the local anesthetic into a blood vessel. And these syringes are designed to aspirate. The thumb ring makes it very easy for the doctor to simply retract the plunger a little bit. On the right-hand side of the screen, you see a positive aspiration, blood coming back into that syringe. It's easy to see and it's easy to do. Also, you have greater control over the syringe. It's more stable, and access to the posterior part of the mouth. When you're doing the inferior dental block, this syringe is designed to give injections in the posterior part of the oral cavity, where your Lurlock syringe and needle system is actually designed for the medical profession. And it works well. Again, I used to work in the operating theater, do anesthesia, and this is what we use. But we're not giving injections in the oral cavity. We're putting drugs either intramuscularly or more commonly intravenously. And for those purposes, it works very, very well. But you know what? The Lurlock system, it is not easy to aspirate with it. You need to use basically two hands to aspirate. And getting access for, let's say, a posterior superior alveolar nerve block in the maxilla or the inferior dental block, it is much more difficult to do this. A second thing to consider is sterilization. And we understand that all drugs, all injectable drugs, better, they not have to be, but better be sterilized. And there are two types of sterilization. We have what is called aseptic and we have terminal. Okay, aseptic, and you're going to see a video of this in just a moment. Each step in the preparation of a local anesthetic is done under sterile conditions. And there probably are 5, 6, 7, 8 steps. And what we're doing is we're hoping, fingers crossed, that we are not breaking that chain of sterility. It's possible. Now, with terminal sterilization, it's the same. The same steps are all done in a sterile environment. But at the very, very end, after the final product is packaged, it is terminally sterilized. And it is done using heat. And what happens then is that if anything, anywhere along the line, any contamination might have occurred during that manufacturing process, we get rid of it. So terminal sterilization does guarantee the highest level of sterility assurance. And in Europe and the United States, terminal sterilization is considered to be the gold standard for drug products and does represent the ultimate safeguard for sterility. In fact, guidelines state that drug products should only be manufactured using aseptic processing when terminal sterilization is not possible. So here's a video that talks about, oh, it actually doesn't talk about it, it shows you the manufacturing process for a local anesthetic cartridge. Okay, if ever you have a chance to visit a manufacturing plant for local anesthetics, please do so. You will be very impressed, as I was the first time I ever saw this. Again, working in the operating theater as an anesthesiologist, I was so impressed with the degree of sterility involved in the manufacture of these medications. Okay, so let's then move on. Parabens. Parabens are bacteriostatic agents, and all multiple dose vials of local anesthetics or any drug do contain them, because if you're going to be putting a needle into that bottle multiple times, you're introducing the risk of contamination. And again, all multiple dose vials of local anesthetics. In India, of course, that's lidocaine and bupivacaine. They do contain methylparaben. And what is the problem with parabens? Even though this is not a very common problem, paraben allergy can occur, does occur. Well, the single-use anesthetic cartridge doesn't need parabens. As you see here, it says no methylparaben formulation to avoid allergic reactions on sensitive patients. So a single-use cartridge does not need to have parabens in them. Another thing is that all of these anesthetic cartridges are latex-free. Many of the multiple dose anesthetic vials do contain a latex stopper at the very top, but all dental cartridges today are latex-free. Accurate dosing. You're using I'm not sure, a 1 ml, 3 ml, 5 ml, 10 ml Lurlock syringe, and you want to load up a certain volume. But you know what? There's always a possibility of operator error when you're filling this manually from a multi-dose vial. Where anesthetic cartridges, you have 1.7 mLs or you have 2.2 mLs, which eliminate the possibility of operator error. You have a fixed volume of anesthetic drug. In addition, the single-use anesthetic cartridge gives you a wide variety of anesthetic options. So on the right-hand side, the two that are available in India right now, we have articaine with epinephrine and we have lidocaine with epinephrine. And you see below that, and you see on the right-hand side, the other anesthetic cartridges that are available worldwide. We have articaine with and without epinephrine, bupivacaine with epinephrine, mepivacaine with or without epinephrine, and prilocaine with or without epinephrine. So there's a wider variety of anesthetics for you to choose from. You don't have that when it comes to the multi-dose vial. Worldwide, most physicians, because they don't use cartridges, do use lidocaine in multi-dose vials and bupivacaine. And that's really the only choice they have. And if you're using multi-dose vials, these are the only choices that you have. Number 7 deals with needle stick injury. And annually, there are about, reported anyway, 2 million worldwide needle stick injuries. And about 60% of them occur in the dental profession. And interestingly enough, or sadly enough, that the Southeast Asia region, which includes India, had the highest prevalence of needle stick injuries. When you're putting a syringe into that multi-dose vial over and over again, there is a greater risk of needle stick injury than there is with that single-use anesthetic cartridge. So this again is just that slide I showed you earlier, which we went over each of these items. The only real advantage, and I don't really believe it is an advantage, is that the multi-dose vial is less expensive than the single-use item. But the point is that the syringe you're using is a plastic disposable syringe, and that adds up over time, the cost. Where the syringe you're using with the single-use cartridge is reusable, sterilizable for years. So this is the armamentarium that I'm looking at, and this is an animation of how this is all going to be put together. That is the harpoon for aspiration. And now we attach the needle. So really, the risk of needle stick injury is minimized with this device and technique. Leonard Mannheim. When I went to dental school, the textbook we used was Mannheim's Local Anesthesia and Pain Control in Dental Practice. He was the guru, and he made this comment: the success of the cartridge system in dentistry has been due to the sincerity, honesty, and high standards of the manufacturers in giving the profession a near perfect product. And I'm going to second that. I believe that the single-use local anesthetic cartridge and the reusable metal dental aspirating syringe are as near perfect as a delivery system for local anesthetics as we can get. So that's our discussion of the delivery system. I want to move on and really finish up, but it's going to take about another 20 minutes or so to discuss a local anesthetic, one specific local anesthetic, and that drug is Articaine. Articaine is the generic name of the drug. Many brand names worldwide. It was synthesized in Germany in 1969 and was introduced into dentistry in 1976. At that time, the brand name of the drug was Ultracaine. Articaine was and still is the only local anesthetic ever designed for the dental profession. Be honest with you, all the other drugs came in multi-dose vials used in medicine. And then a dental profession came along and put them in cartridges. This is our drug. 1976 in Germany. Articaine, the most common formulations of Articaine are 4% with epinephrine, 1 in 100,000, which is what is available to you in India, and epinephrine in 1 in 200,000. And it's interesting, considering the fact that this is the newest of our local anesthetics, the market share of this drug. I mean, yes, it was introduced in Germany. 98% of local anesthetic usage by German dentists is Articaine. Throughout Europe, 90% in Poland, 81% in France, Bulgaria, 56%, Italy, 53%. In Canada, 49% of the market, and in the United States, we didn't get the drug until the year 2000, but in the United States, a 41% market share. And it fits into the category of the intermediate acting drugs. These are the drugs that should, if the patient responds appropriately to the medication, give you about 1 hour, 60 minutes worth of pulpal anesthesia. And I got to admit to you that I like Articaine. I love Articaine, actually. And one of the reasons was I was introduced to it early. And in fact, in the United States, where we got the drug approved by our Food and Drug Administration in the year 2000, I was involved in doing the clinical research, the phase 3 clinical trials to get this drug approved. And these are 3 of the papers of the studies that we did to get this drug approved in the United States. And I am one of the authors of each of these 3 papers. So why do I like Articaine? And well, there are 2 reasons. And I again, because of time, I need to go into this a little bit quickly, but I like Articaine because it's eliminated from the blood more rapidly than other local anesthetics. And number 2, because of its lipid solubility. So allow me to explain. Upper left, Procaine, categorized as an ester type local anesthetic. Circled in blue is the ester linkage. All ester local anesthetics have that in common. On the right, lidocaine, an amide. In pink, that is the amide linkage. All of the amide local anesthetics have that in common. Articaine is a hybrid. Yes, we classify Articaine as an amide local anesthetic, but in actual fact, it is a combination of an ester and an amide local anesthetic. And that confers on it some interesting properties. And there's a third one. So you see here, number 2 and number 3 are the amide linkage and the ester linkage. And number 1 is the thiophene ring. And I'll explain to why that's important in a moment. But all other local anesthetics have what is called a benzene ring, where articaine has a thiophene ring. So the question is, why are these structural differences important? And let's go back to the first reason I like articaine. Well, let me go back to that slide. More rapid elimination. And to me, that is safety. Now, keep in mind that all local anesthetics are extremely safe when used properly. So let's then very briefly look at what is the major drug-related complication that is associated with the administration of a local anesthetic. And the answer is it's local anesthetic overdose. An overdose of any drug, not just a local anesthetic, of any drug, occurs when its blood level in its target organ is too high. Well, the target organ is a place in the body where a drug does something. And you understand that local anesthetics block nerve conduction. Well, the brain is a target organ. And if the blood level of local anesthetic in the brain gets too high, it produces a problem. And the most common etiology of a local anesthetic overdose is giving too much. Usually it's giving too much to a child who weighs under 30 kilograms. Now also keep in mind that one cartridge of any local anesthetic, including articaine, one cartridge of any local anesthetic administered intravenously rapidly will, without any doubt, produce an overdose. But we're now talking about the most common reason, and that is administering the drug properly, but simply giving too much to a smaller patient. Okay, so let's look at this. This is a slide that talks about what is called the elimination half-life of a local anesthetic. Once that drug leaves the nerve, how long does it take for it to be metabolized? Okay, keep in mind that the half-life of a drug has nothing to do with its clinical duration of action. So these drugs, procaine and tetracaine, as long as they stay in that nerve in a high enough concentration, are blocking nerve conduction. How do drugs stop working? How does anesthesia stop? The drug diffuses out of the nerve into capillaries, veins, goes to the heart, and then circulates throughout the body. So the half-life is how much time it takes for the blood level of that medication to be decreased by 50% once it leaves the nerve. And if you look at procaine, Novocaine, the half-life is 6 minutes. In 6 minutes, blood levels decrease by 50%. We normally say that a drug is gone from your cardiovascular system in 6 half-lives. So in 36 minutes, procaine is essentially, it's actually 98.75% decrease the blood level. Now look at the amides. See, the esters are metabolized in the blood as soon as they leave the nerve. The amides on the bottom of the screen have to reach the liver. They're not metabolized in the blood. And the half-life of these drugs is considerably longer. Lidocaine, 90 minutes. 6 times its half-life is 9 hours. So let's look at articaine. Articaine, as I said earlier, is a combination ester and an amide. And when it comes to metabolism, 90 to 95% of articaine is metabolized like the esters in the patient's blood. And here's a study done, a chart from a study done by Dr. Wolfgang Jakob in Germany, where they injected 120 milligrams of lidocaine and articaine and measured the blood level over 90 minutes. And you can see very easily that the blood level of articaine decreases significantly more rapidly. Again, lower blood level, a lower risk of an overdose occurring. And there, this is a slide I showed you earlier, but I've inserted articaine, where the half-life of articaine is 27 minutes. 6 times the half-life is 162 minutes, or 2 hours and 42 minutes, comparing it to the other amide local anesthetics significantly more rapidly. So the elimination half-life, these are studies that were done on 3 different groups of patients. In adults, between 20 and 27 minutes. Half-life in pediatrics, 18 to 23 minutes. And in geriatric patients, about 27 minutes, comparing it to 90 minutes for your lidocaine. And this is the reason, the half-life, that is my opinion, that articaine is the indicated local anesthetic in patients who are pregnant, who are nursing, in pediatrics, and in geriatrics. Now, the other reason I like articaine is lipid solubility. In order for a local anesthetic to enter a nerve and block nerve conduction, it has to be lipid soluble. So I mentioned earlier in the right-hand slide that all the other local anesthetics, the lidocaine, mepivacaine, prilocaine, bupivacaine, to be lipid soluble, have a benzene ring, and articaine doesn't. Articaine has a thiophene ring. Well, very, very simply put, articaine, the thiophene ring is more lipid soluble than benzene. Okay, so now why is this important? Or what is the clinical significance? Well, it diffuses through soft and hard tissues better than other local anesthetics. So let's take a look at this. One of the problems that we have in dentistry, and I've given many, many courses on this, is the mandibular block. Okay, troubleshooting the mandibular block. And the problem is that in an adult patient, the cortical plate of bone, especially in the molar region, is very thick. And it precludes the administration, the successful administration of infiltration. In the maxilla, infiltration, because the cortical plate of bone is usually very, very thin, infiltration works, but not so in the adult mandible. So let's take a look at the use of articaine, comparing articaine to lidocaine as a primary technique, mandibular buccal infiltration. And in this study from 2007, they infiltrated by a mandibular first molar, you can see the syringe, a full cartridge of either articaine or lidocaine, and they then pulp tested every 3 minutes for an hour, and success was based upon 2 consecutive pulp tests with no response. Look at the difference. Second molar, 75% versus 45% for articaine. First molar, 87-57, 92-67 on second premolars, and 86 versus 61% articaine in the mandibular first premolar. Well, I mentioned earlier that articaine was introduced into the United States in the year 2000. And let's sort of jump ahead now to early in 2001. And I'm giving a lecture, 500 or so doctors listening, and I asked them the question, do you use articaine? And if you like it, do you like it? Yes. And if you like it, why? And these are the things they told me. I like articaine because it works faster, because it works better. Patients who are usually hard to get numb are easier to numb with articaine, and I don't miss as often. Now, keep in mind that this is not science. This is, in my opinion, they're telling me. This is anecdotal evidence. Well, here's science. In that study I just showed you where they infiltrated articaine in the buccal fold by a mandibular first molar, or they infiltrated lidocaine, look at the difference in the onset of pulpal anesthesia. Lidocaine was 11 minutes, 7 minutes, 6.9, and 6.3 minutes, where with articaine, the infiltration was 4 minutes and change. Yes, it does diffuse better. So let's take a look at another study, another interesting thing, and that is using articaine by mandibular buccal infiltration as a supplement to a previously administered inferior alveolar nerve block. In this study published in the UK, actually in the International Endodontic Journal in 2009. So patients came in twice. They received a lidocaine inferior dental block. On one occasion, they got a supplemental articaine buccal infiltration by the first molar. On the other occasion, they got the lidocaine IDB, and they got a sham injection. This 55.6% is the inferior, the IDB without the articaine buccal infiltration. This slide shows you the difference. These are the patients when they got the articaine mandibular buccal infiltration after the lidocaine IDB, 91.7%. And at the end of the study at 45 minutes, there's no indication of the anesthesia dissipating. This is an email I got last year. I found it interesting. This is a dentist who practices in New Orleans, which is one of the cities in the South in the US. And he writes down that I have been in private practice for only 42 years, so I know nothing. I hope this email is still active and you have time to answer. He went on to mention a couple of things, but it's the PS on the bottom. Ceftocaine is the brand name, of one of the brand names of Articaine here in the United States. So let's change that to Articaine. Articaine Infiltrate on lower molars is the best thing ever in 42 years. Recently this year in February, I was in Saudi Arabia. I spoke at the Saudi International Dental Congress that was held in Riyadh, Saudi Arabia. And this is one of the doctors who heard my talk on local anesthetics. Let me just read this to you. Thank you very much for sharing your insights about Articaine. I would rather call it the magic local anesthetic, as I have been using it over the last few days and have found perfect results, especially when extracting symptomatic mandibular molars. One buccal infiltration with Articaine saves the day for me and my patients. Here's a question. Do your patients enjoy receiving palatal injections? Another question, do you enjoy giving palatal injections? And I know the answer to that is no. So here's a recent study that and this is something that you can start doing. You'll love it. Your patients will love it. Using a maxillary buccal infiltration of Articaine to achieve palatal anesthesia. Big study, 300 patients having one maxillary permanent tooth extracted either in the anterior, premolar, or molar region. And what they did was they started out by administering a third of a cartridge, 0.6 mLs of lidocaine or Articaine in the buccal fold, and they waited 2 minutes, and they assessed palatal anesthesia. If the patient didn't have palatal anesthesia after 2 minutes, they gave another 0.6 and waited 2 more minutes. So at the end of 4 minutes, they had 2/3 of a cartridge, 1.2 mils. They tested again. And if they didn't have palatal anesthesia after 4 minutes, they gave the rest of the cartridge. So now they have a full 1.8 mLs of either lidocaine or Articaine by buccal infiltration. And at the end of 6 minutes, they assessed for palatal anesthesia. Well, this is lidocaine. At the end of the 6 minutes, a full cartridge of lidocaine, 1.3% of the patients had palatal soft tissue anesthesia. At the same time, 82.7% of the patients receiving Articaine at the end of 6 minutes had palatal soft tissue anesthesia adequate to extract a permanent tooth painlessly. 82.7% versus 1.3. Think about that. Okay, you may not have to give palatal injections again. You're going to love it, as will your patients. And they found no significant difference between the anterior, premolar, or molar region. So I want to add something to this, because at the end of the 6 minutes, 82% of the patients had palatal soft tissue anesthesia with Articaine. And it says here, this is from the article, that the other 17% required a supplemental palatal infiltration. Okay, they didn't have profound palatal anesthesia, but they had some. So if you have to go in and give a palatal injection after 6 minutes, they won't feel it because they have some degree of anesthesia. But the other thing is this, they only waited 6 minutes, where most dentists after an injection will wait about 10. And if you were simply to wait another 2 minutes, 8 minutes, or wait 10 minutes, that 82.7% is going to be higher. So that again is one of the 2 things I want you to take home with you after this program is over. Now, let's go to this, okay? Lidocaine, mepivacaine, and prilocaine are excellent and they are safe local anesthetics. But is Articaine better and a safer local anesthetic than the other drugs? And in my opinion, the answer is absolutely yes, when used properly, as with any other local anesthetic. Why? Well, I gave you the 2 reasons. I gave you the short version, but number 1, it is eliminated more rapidly once it leaves the nerve which increases its safety. And number 2 is its lipid solubility, the ability to diffuse through hard and soft tissue into nerves better than other local anesthetics. So again, in my opinion, and this is what you saw earlier, articaine to me is the indicated local anesthetic in pregnant patients, nursing mothers, pediatric patients, and geriatric patients because of its shorter half-life, indicated for mandibular infiltration in adults, and maxillary infiltration for palatal anesthesia because of its increased lipid solubility. So as a take-home, please start using articaine. Use it by buccal infiltration in adults for mandibular molars, either alone or as a addition to a previously administered inferior dental block, and start using articaine by maxillary buccal infiltration, a full cartridge, waiting about 6, 8, or 10 minutes to achieve palatal soft tissue anesthesia. If anybody wants, I can send you a lot of additional information. And if you just email me about articaine, I will be glad to send you a packet of information, articles and such discussing articaine in these special patient populations. And I also want to please, mention again that I consider the single-use local anesthetic cartridge and the reusable metal dental syringe to be a near perfect delivery system for local anesthetics in the dental setting. So let me just go back and one more time look at that email from that doctor from India, trained in India, who came to the United States last year. After having worked with aspirating syringes here in the US, I was hoping there was a way to bring that system to India. And she finished up, I am sure your webinar will serve as a great impetus for dentists practicing in India. So here's my email address. One more time, please feel free to contact me with questions, anything about local anesthesia, medical emergencies, sedation, physical evaluation. I will respond, I promise you. One more thing, tomorrow I am doing a webinar for Septidont, and it actually is discussing, it says here local anesthesia for special needs patients. We're discussing pregnancy, nursing, pediatrics, and geriatrics. So if you simply go to septidont.com, perhaps you can sign up and view this webinar. With that, again, I want to thank you all very, very much. It's been a pleasure. I truly hope I have the occasion to visit your marvelous country at least one more time in the not too distant future. Thank you all very, very much.
Thank you, Professor Malamed, for that wonderful presentation. I'm sure you all are enlightened with that presentation. And few questions have started pouring in.
Okay.
The one which is how to give more painless anesthesia in pediatric dentistry.
Okay, let me go back to this slide right here then. Pediatric dentistry, giving painless injections anywhere for anybody, not just pediatrics, of course. But pediatrics, if you hurt a child, you maybe ruined him he or her as a patient for life. Couple of things, okay? Probably the most important thing is slow deposition of the drug. Slow, okay? And I can't stress that enough, because speed hurts. When you put local anesthetics in rapidly, they don't diffuse, they tear tissue. When you inject the drug slowly, they diffuse and it doesn't hurt. Using topical anesthetic at the injection site, just a little bit of topical, leaving it on that tissue for about 1 minute on a cotton applicator stick. Okay, let's go back. Dry the tissue, apply the topical anesthetic, leave it there for 1 minute, stretch the tissue, make it nice and taut, tight, and when you insert that needle, slowly deposit that drug. And that, it's not magic. It does work. It does work. Now, there's something I'll just bring it up. It wasn't part of the webinar, and it's not available actually in India, but we have started here in the United States buffering our local anesthetics. Now, long story short, local anesthetics, which contain epinephrine and adrenaline, have a very, very low pH. The pH is around 3.5. They're highly acidic. What we're doing is we're adding a buffering agent called sodium bicarbonate, a little bit of it, to our cartridges, and we're raising the pH of the cartridge to around 7.4. And we inject the drug, and it has a couple of advantages. It's much more comfortable for the patient. It makes the drug work much more rapidly. It speeds the onset of anesthesia. It gives us more profound anesthesia. Now, again, it is not currently available outside the United States, but this is something that you should think about when it becomes available in India. It's one of those two things. The two things that I have been pushing, emphasizing in my local anesthetic lectures is the use of articaine by buccal infiltration in the mandible, by buccal infiltration on the palate to get soft tissue, buccal infiltration to get palatal soft tissue anesthesia in the maxilla, and buffering. I truly believe that these are very important components of painless injections, making our patients more comfortable.
Thank you very much. And there is one more question. Any contradiction with articaine? Contraindication with articaine?
I can think of no specific contraindications. I mean, if there were a contraindication in a given patient to the use of a local anesthetic in general, then any local anesthetic would be contraindicated. But I cannot think of a specific contraindication that articaine would possess. That's the best answer I can give. Nothing specific for articaine. But if that patient had a contraindication to getting local anesthetic injections in general, that would rule out the use of articaine as well.
Okay, thank you. There is one more question. If there is a periapical infection, just single cartridge of articaine is enough?
If there is periapical infection, a single cartridge of nothing is going to work that well. One of the lectures, in fact, this is the at the International Endodontic meeting last year, which was supposed to be in Chennai, which was done virtually. I spoke at what I call the dilemma of the hot mandibular molar, which is the hardest tooth in the oral cavity to anesthetize. Mandibular molars, when they're not infected, are the most difficult teeth to anesthetize. When they become infected, they're really tough. And no, one cartridge of articaine might work, but again, if you have an infected tooth with a periapical abscess, a periapical infection, all bets are off. Again, in that 2 or 3 hour program I give, I go through an entire list of things that you should do. But no, the answer to that question is no. One cartridge of articaine or lidocaine would probably not be adequate with an infected tooth.
There is one interesting question. Can two different anesthesia be used in single patient, like lidocaine for block and articaine for infiltration?
Yes, absolutely. And then, in fact, what you just said is the way lidocaine is still the most used local anesthetic worldwide in dentistry. So let's talk about we're doing the IDB, okay, the inferior dental block with lidocaine with epinephrine. And what I would like you to do, as I said, I want you to keep, let me go back to a couple of slides here. What I want you to do, here we go, following your IDB with lidocaine, I want you to take your articaine and do a buccal infiltration at the apex of whichever mandibular molar you're treating. You know, it doesn't mention premolars or mandibular anterior teeth because you have the mental foramen, and doing what is called technically correct an incisive nerve block, which is incorrectly called a mental nerve block, You can get anesthesia of the premolars, the canine and incisors. But again, it's those mandibular molars that are so difficult to treat. And if you simply do your IDB with lidocaine or articaine, following it with a articaine buccal infiltration of about a half, well, again, not using cartridges, but yes, articaine only comes in cartridges, of half to 2/3 of an articaine cartridge in a buccal fold by the mandibular molar you're treating, you will have a dramatic success rate increase. The slide I showed you earlier in the study, the lidocaine IDB was a 55% success rate when they gave the same patients a lidocaine block with an articaine buccal infiltration. It went to 91%. Keep that in mind and start doing it. It'll help you tremendously.
Now, there is a very common question by quite a good number of dentists. Can articaine be given as block? And if at all it can be, what about paresthesia?
Okay, so again, if we had a 3-hour presentation, I could talk for quite a long time about this paresthesia, in quotes, controversy. Obviously, you've heard about this. That's why the questions came up. And let me go back to my email address. Okay, email address, there we go. I will send, if any of you are interested in, I'll tell you what my feeling is in a moment, but if anybody wants a lot of scientific information about paresthesia in dentistry and specifically discussing articaine, email me. I'll send you a good amount of information. There is, in my opinion, there is no scientific evidence whatsoever that articaine has a higher risk of producing paresthesia when given by IDB. When it first came on the market in the United States in the year 2000, there was a controversy. There was. And, 90% of paresthesia that occurs in dentistry occurs in the mandible. And of that, about 75 to 90% only involve the lingual nerve. Think about when you're giving the IDB, how much local anesthetic you're giving to anesthetize the inferior alveolar nerve, and how little anesthetic, if any, you're depositing to get the lingual nerve. And it makes no sense that if the drug itself, if articaine is more neurotoxic, it damages nerves. The IDB, the inferior alveolar nerve, would be the one primarily affected. You would see paresthesia occurring of the patient's lip, the buccal soft tissue. But no, you don't. It's almost always the lingual nerve. And to make a long story short, again, I will send you this information if you want it. The reason is when you're giving the IDB, the lingual nerve is in the way. The anatomy, as you penetrate that soft tissue and you're aiming for the lingual aspect of the mandibular ramen, mandibular condyle. Your needle is passing very close to the lingual nerve. And also keep in mind that once that needle penetrates that patient's mucous membrane, the injection is blind. You can't see where you're going. So on very rare occasion, either the patient's anatomy is a little bit different or the needle is a little bit off to the side, you can't see it, it contacts the lingual nerve. Is that malpractice? Absolutely not. It's bad luck. Stuff happens. Paresthesia has existed in our profession way before the introduction of articaine. And it almost always involves the lingual nerve. So it's not the drug, it's mechanical trauma produced by the metal needle coming into contact with that nerve. That's that's by far the most likely reason. Again, without going into a lot more detail, please, if you have an interest in this, email me. I can send you a packet of stuff, articles and such that discuss the question of paresthesia.
Doctor, there are a good number of queries pouring in. What we are doing is that we have noted down those queries and we will directly mail it to you. So this is what we suggest because it's already 11:15 and just last question. Can we take it, doctor? Just one last query. Is it possible?
Yes. Yeah, of course. Go ahead.
Is 1:200,000 adrenaline safe for cardiovascular disease patient compared to plain anesthetics without adrenaline?
Okay, well, the first question I would bring up to whoever wrote that is, to my knowledge, there are no local anesthetics available in India without epinephrine. There are no plain drugs. But let's go back to this. Something just happened. Can you hear me now? Yeah.
Yeah.
Okay. A patient who has, a lot of patients have cardiovascular disease. It's something that happens as we get older. If a patient with cardiovascular disease is treatable, now I'm not sure how familiar you are with what we call the ASA physical status classification system. It's a way of classifying a patient's risk during general anesthesia. We've been using this in dentistry now since the 1970s here in North America. A patient who is perfectly healthy is categorized as an ASA1. They have no medical problems whatsoever. If they have a mild medical problem, not life-threatening, they're an ASA2. If they have a more severe medical problem that limits their activity, they're an ASA3. And if they have a severe problem that is constantly life-threatening, they're an ASA4. Let me just do it a different way. Traffic lights. A person who's an ASA1, perfectly healthy, is a green traffic light. A person who is an ASA2 or a 3 is a yellow or amber traffic light. It means proceed with caution. And a red traffic light, hopefully, means stop. So if we're classifying a patient with cardiovascular disease as an ASA2 or 3, patients with angina, patients with slightly elevated blood pressure, patients who had a myocardial infarction and have recovered, they're ASA3s. The use of local anesthetic with epinephrine, adrenaline, is okay. There's no problem. In fact, you can get better, you will get better anesthesia than you would with a plain drug. If you use a plain drug on a patient and the anesthetic doesn't work well and you hurt them, the amount of epinephrine and norepinephrine released from the adrenal gland is so much greater than the amount of epinephrine that is located in a dental cartridge. So the answer to the question is, if somebody has cardiovascular disease and they're deemed to be treatable, then the use of a local anesthetic with 1 in 200,000 epinephrine is the preferred way to go.
Thank you very much, Professor Malamed. And what better this could have been than you coming live rather than a recorded webinar. So really we are fortunate enough to come for you coming live on this. I thank you once again. And at the same time, I thank all the participants. It's 11:20 in India now. And I really appreciate your enthusiasm to know more about anesthesia. Thanks a lot. Thank you very much once again, Professor Malamed. Have a wonderful day.
Thank you. My pleasure, and thank you for inviting me.
Thank you very much. Thank you, and good night to all the doctors in India.